we're going to move on to our last talk of the day. This is going to be Dr. Oren Davinsky talking about sleep, cognitive, and other non-seizure disorders in Dravet syndrome. And so just to introduce you to Dr. Davinsky, he's a professor of neurology, neurosurgery, and psychiatry at the New York University School of Medicine. His epilepsy research includes SUDEP, cannabinoids, phenome-genome correlations, autism, neural markers and imaging, therapeutic electrical stimulation, quality of life, cognitive and behavioral issues, and surgical therapy. He's been the principal investigator for the North American SUDEP Registry, and he's on the executive committee of the SUDEP Institute. He's chaired several committees for the Epilepsy Foundation and the American Epilepsy Society, and has served as a board member of both organizations. He founded Finding a Cure for Epilepsy and Seizures, FACES, and co-founded the Epilepsy Therapy Project and epilepsy.com. Some of his outside interests include behavioral neurology, evolutionary biology, and the history of neuroscience. We're so excited to hear from Dr. Davinsky today, and hopefully we will have a few moments for questions at the end of his talk.
Hello, this is Oren Davinsky, and I'm honored to be here today talking about sleep, cognitive and non-seizure disorders in individuals with Dravet syndrome. Seizures are the initial and most serious symptom in Dravet syndrome patients, but most patients later develop cognitive, behavioral, sleep, and motor symptoms that vary when they present and their severity. Developmental delays in cognitive and motor performance often emerge by the second year of life. Convulsive seizure frequency and severity can negatively impact function over time, but this has been hard to prove definitively. Sleep disorders are commonly reported, and impaired sleep we know can increase seizure frequency and can lead to impairments in consolidation of short-term memory and mood and other issues. So what are some of the common comorbidities based upon interviews with families regarding their children? Sleep disturbance actually tops the list, with 85% of parents reporting that their child has some sleep disturbance. Gait disturbances, autistic traits, language impairment, difficulties with impulse control, and potentially endocrine issues as reduced height and weight, possibly related to low insulin-like growth factor and testosterone, are less clearly associated with Dravet, but have been suggested in several studies. There's a large number of other problems and issues that families have reported, from constipation and pottying leading to seizures, inability to tolerate cold, lack of sweating, lack of response to pain, lighter skin, scoliosis, preferring to play with adults, which is common in many children with developmental disabilities. So a large number of other symptoms are reported, although these remain to be scientifically validated and studied with regards to how often they occur, whether some of these are coincidental or indeed true associations specific to Dravet, or really symptoms more common in many children with developmental delays and epilepsy. So what can we say about seizures and sleep in Dravet syndrome? Now, we're not talking about sleep problems here, but the relationship between sleep and seizures. So under age 5 years of age, major seizures often occur around the time of awakening. After age 5, many major seizures occur during sleep. And this, of course, is very relevant for those of us, and I think all the parents who are concerned about the possibility of sudden unexpected death in epilepsy, or status, which is most dangerous if it occurs during sleep hours. Myoclonic seizures may be more frequent on awakening, and they tend to be absent in non-REM sleep. That's the portion of sleep where dreams tend to be uncommon. And for many children and young adults with Dravet syndrome, focal EEG abnormalities, not the generalized ones, but the focal ones, may be activated in sleep. So I'm going to go through some different surveys done by different investigators in different parts of the world on sleep issues. So this is one that was done several years ago from an Australian group. and about 75% of their patients were reported to have sleep problems in a population that ranged from 2 to 36 years with an average age of 14. There was difficulty initiating and maintaining sleep, difficulty with sleep-wake transition, issues with sleep-breathing disorders, and the requirement of medications, usually melatonin, to help these children fall asleep and stay asleep. Nocturnal seizures were reported by about half, and then issues with oxygen desaturation, more than 3%, which is not that clinically significant, but certainly not normal either, in about 80% of these children, and higher mean pulse rates in almost 40%. In Belgium, 52 families were surveyed, of which it's actually 42%, I think it's 22 out of 52, had issues with sleep. Severe sleep problems occurred in 28%, usually night wakening or daytime sleepiness, and a control group of other epilepsies reported sleep problems in only 21%, so not that much different. And in looking at the Dravet syndrome versus other epilepsy controls, there were really no significant differences except for higher daytime sleepiness in Dravet syndrome patients, and parent-reported quality of sleep was lower in the Dravet syndrome cases. In the United States, this is a survey done through the Dravet Syndrome Foundation and Dr. Knupp at Colorado Children's Hospital. A large number, 202, were surveyed, and sleep problems again were found in about 80% of the patients reported by the family, apnea in 30%, difficulty falling asleep and awakenings from sleep in about 2/3 of patients each, and short sleep time in about 50% of these predominantly pediatric patients. And this is a smaller survey of patients in Rochester, Minnesota, of Dravet children who underwent polysomnography, which is a sleep study. The sleep microarchitecture was normal. There were some slight changes in non-REM sleep microarchitecture with a mild increase in immature patterns. But overall, the take-home message from this study is that formal sleep evaluation in these 6 Dravet children was actually normal. So I'm going to change the topic now to a very important one, and that is the issue of cognitive decline. And this is from a study done almost a decade ago, published in Epilepsia by Ragona and colleagues. These are 26 children, all with cognitive decline beginning in the 2nd year of life, which is typical for Dravet. Early absence and myoclonic seizures, interestingly in the study, were associated with a less favorable outcome, while convulsive seizures and status did not clearly have an effect on outcome, although other studies have found different findings for this. But unfortunately, as you can see, the general quotient of intelligence, although very hard to assess really in a 1-year-old or 6-month-old, but unfortunately the general trajectory is what you can see here over the course of time by age 7 or 8 years, which is to the far right of this figure, which is in months. These children suffer progressive reductions in their cognitive function. So this study from Belgium looked at the relationship of seizures and different issues in Dravet syndrome patients. And CSF here is convulsive seizure frequency, so some measure of seizure burden. And the two things that were significant is the greater the convulsive seizure burden, the more impaired motor and speech functions are. Other issues like learning difficulties, autism, ADHD, or other behavioral issues really did not distinguish between the high and low seizure burden groups. So how do we manage comorbidities? As important as reducing seizures are, trying to reduce the impact of Dravet syndrome on language and other cognitive functions, social and emotional and other behavioral functions, motor functions like walking, are all really, really important. And it's important to recognize what are the treatment-related side effects. Sadly, many of the medications that epilepsy physicians use to treat Dravet syndrome may actually lead to side effects that could impair cognition, behavior, motor performance, etc. And it's hard to assess comorbidities in clinical trials as it often requires time to improve and worsen, and many of the clinical trials look at seizures or drugs that reduce seizures. So if seizures go down, not surprisingly, many other functions will improve. If a child's having many seizures during that period of time, their attention span, their memory, their walking, their coordination may all be impaired. And if they can go for a month with no seizures, all those things get better. So is that the effect of the drug on disease modification, or it's simply the effect of the drug on reducing seizures? And how do we ultimately improve quality of life and increase the probability that a child could attain independence? So there are a number of scales I'm not going to get into in too much detail, but the pediatric quality of life is a more generic one. The COLSI is a bit more specific to epilepsy. And then there are very broad things like clinical global impression of change. From the last time we saw you to now, is your child better, less good? Very commonly used in clinical trials. And then there's the BRIEF-2, which is a specific questionnaire focusing on cognitive functions. And within the BRIEF-2, these are some of the cognitive variables looked at: executive, which is more planning, judgment, reasoning; regulation, the ability to monitor and control impulses; emotional regulation, set shift, can they change in different environments and transition; and then cognitive regulation, which is a child's ability to control and manage cognitive processes and solve problems effectively. So I'm going to look at some of the data from the fenfluramine open label extension, and this is just, I think, an exemplar. Fenfluramine is clearly a very important medication in Dravet therapy, and the study looked at ages 2 to 18-year-old children who participated in open label extension from a double-blind study. The percent difference in convulsive seizure frequency per 28 days was calculated comparing to baseline, and there were 53 children who were studied with a median age of 10 years, and the median reduction in seizures before randomization in convulsive seizure frequency was actually a 71% reduction, and the responder rate, actually 45% of patients had a greater than or equal to 75% reduction in convulsive seizures. So looking at some of the median changes in the BRIEF-2 scores for patients treated 1 year with fenfluramine, and the negative scores that go below the line, that is, the purple ones are individuals, the purple ones are individuals with a greater than or equal to 75% reduction in seizures. And you can see that for all of those who had that significant reduction in seizures, there was improvement in executive function, a very important cognitive function of planning, judgment, reasoning, that these children, when their seizures really came under much better control, their cognitive functions improved, not surprisingly. And this is another slide that looks at the change in seizure frequency, correlations with the BRIEF-2, and again, what you can see is for 3 of the major scales in the BRIEF-2, there was a clear association. As seizures were reduced, cognitive functions improved. This again looks at emotional regulation for patients treated for 1 year, and again, there's a positive relationship here. The better the seizure control, the better the emotional regulation index. And then here's global executive composite from the BRIEF-2 scale, and again, the same positive association. The better the seizure control, the better the cognitive function. And we certainly see this with other epilepsy syndromes, and it's not surprising, of course. Seizures are not good for the brain. Convulsive seizures are probably the worst, and if you can control them, the child's brain functions better. So what about clinically meaningful changes? This is when there's a profound reduction in convulsive seizure frequency, there's a consistently greater proportion of patients who have improvement in executive function on all 4 index scores. So again, this slide makes points made previously. These are very significant improvements in these cognitive measures, and they all occur in the children who had the greatest reduction in seizures. So to summarize, sleep is often disturbed in children with Dravet syndrome, but there's been relatively little systematic research on this beyond questionnaires to ask parents. In the few studies where polysomnograms are done, the children actually look fairly normal. And when they're compared to other epilepsy cohorts, they also look similar. The mechanisms underlying cognitive and behavioral disorders likely include the underlying genetic disorder, for example, SCN1A loss of functions or haploinsufficiency, as well as convulsive seizures, and also medications. Effective, well-tolerated treatments that profoundly reduce seizures will likely improve cognition and behavior, and we've seen that in Dravet trials. It is never too late to see non-seizure related improvements that positively impact cognition and improve quality of life. I've seen such improvements in 30-year-olds when seizures come under control or other measures are taken to improve their neurologic condition. And earlier effective seizure control could lessen the potentially long-term chronic developmental, cognitive, and behavioral impacts of Dravet syndrome. Thank you very much. And I think we'll open it up for questions at this time.
Do a Q&A with Dr. Davinsky. So if anyone has any additional questions that they haven't asked yet, make sure you get those in the chat. And I will just start with the first question that I see, which is, our 6-year-old daughter has a lot of involuntary limb movement during sleep. What are your thoughts? What could be the connection with Dravet, and what kind of treatment might something like this need?
So it's a great question. It's a not uncommon observation by parents with Dravet, and to be candid, with other epilepsies as well. So one of the big questions is, are they myoclonic seizures? Children with Dravet do have myoclonic seizures during daytime. They're frequent in transition into or out of sleep. They're a bit less common during sleep, but not impossible. So for a case like this, I think either a 24-hour home EEG or inpatient monitoring where they can correlate the actual jerks, and if the parents can watch and press the button when the child does have the jerk. Typically, myoclonic seizures show up nicely on the EEG. So I think if they are surface negative, or you see a jerk and the EEG is unchanged, other than potentially muscle activity, then I think we can be pretty confident it is not a seizure. And many children do have twitchy movements in sleep. There's a saying for neurologists, when you're young and you finally graduate neurology residency, don't watch your kids sleep. It'll drive you crazy.
Thank you for that good advice. I've seen lots of concern about this kind of stuff in the community, and going back and forth of, what's normal movement during sleep and what's a seizure. And so I think it's a really relevant concern. Another question we just got through is, with improved sleep, is there a reduced chance or a reduced degree of cognitive decline?
Again, a great question. I don't think that's been well studied in Dravet, but certainly in other disorders, even dementia, people who sleep better tend to have better cognitive function. So I think both with regards, good sleep ensures a reduced chance of seizures, because we know one of the best ways to produce seizures, other than withdrawing medications, is to sleep deprive children or adults to produce a seizure. So I think good sleep is important for seizure control, it's important for mood, and it's important for cognitive function. I think we all know when I was 20 or 30, I could get away with a lack of sleep and function at relatively good cognitive performance. But as I got older, I found out that my cognitive deficits were pretty dramatic on a night of bad sleep. So I think the same is true for children. It may be more subtle, but it's there.
Okay, so here's another really great question that I think you might be able to shed more light on. So now that we have enough patients with Dravet syndrome in the US to really be able to look at SUDEP, specifically nighttime mortality, are any researchers interested in conducting a multi-center study on sleep monitoring and SUDEP incidence?
So again, a very, very good question, one dear to my heart. I've been involved with SUDEP research for well over a decade now. And I think you're absolutely right. I think the time is now to do these types of studies. That there are several challenges in doing them. Although SUDEP is sadly very common in Dravet, in some studies up to 20% of children will die from SUDEP or status or drowning by age 20. The reality is, following, let's just say, 300 children with Dravet syndrome for 5 years is a long process. And then, of course, I've been involved with programs. There's a group home which has a large number of children with developmental disabilities, and they've been around for decades. And all of a sudden, in a 6-month period, I think 2 young adults died of SUDEP. And so understandably, the parents were enormously concerned. I went over with the facility and advised them, for anyone with a history of nocturnal seizures, to get a watch that could detect seizures. And they had a rigorous training, and all the counselors were informed. And sure enough, 3 months later, someone died from SUDEP. And it was a young adult who took the watch off before he went to sleep. He just didn't like it, took it off. It was on his nightstand, so of course it didn't detect the seizure. My point is, I do think nocturnal monitoring probably works. I think we have enough evidence. There are a lot of studies where, for example, in England and Denmark, they compare young adults who either go home and are not monitored, or are in a residential setting where they're very closely monitored with noise, with sound detectors, with counselors coming by every 15 minutes. And the rate of SUDEP is phenomenally lower when the children or young adults are monitored. So I do think I would advise, I think, and that brings the second part of the challenge, because so many of these children are at high risk with Dravet. It would be very hard to randomize a group of children and say, Mrs. Jones, you're in the group that doesn't get the device, and Mr. Smith, you're in the group that does get the device. I think understandably, devising those trials will be challenging. So I'm involved with a number of multi-center. One actually now has 86 sites around the world collaborating on SUDEP research. So I think there is a lot of interest on the academic side to do this, and I'd be very open to speak to people at Dravet Syndrome Foundation and the mom or dad who asked that question, and thinking about the challenges in doing this kind of study. I think the time is now to do it. There are more and more devices, but to think about how to do the study, how long, how many individuals would need to be enrolled, and the ethical issues. Do you ask one group not to go on a device, or do you compare device A to B? In which case, they'll probably both work fairly well, and you may have to enroll 1,000 people for 10 years to see a difference.
Thank you. Man, we're getting a lot of questions rolling in. Let's see. I have a couple of questions. I'm going to hit this one because I saw someone asking something similar in an earlier session that we didn't get to. Your thoughts on neurofeedback and alternative treatments in addition to pharmacological therapies that might... I lost the question. In addition, so your thoughts on neurofeedback and alternative treatments besides pharmacological for awakening seizures.
So again, something in my career, I've actually written 2 books on alternative therapies for epilepsy. Based on a conference with people flying in from India, Scandinavia, Europe, everywhere. The reality is that, my religion is science, and science means you doubt things until someone proves it, because everybody has a million theories. You take the presidential election, there are people who are absolutely convinced one of the candidates is the best person in the world, and others think it's the worst person in the world. I'm not here to discuss politics or religion, but that's the point. There's no hard data. I may have my own opinion, but it's not a scientific discussion in most cases. With therapy, you need science, because you go to a push cart on Houston Avenue in 1910, and there would be Dr. Jones's tonic, and it would be good for everything from hair loss to cancer to epilepsy to neurasthenia and hysteria. And the reality is some of those things may have worked, most didn't. And having gone through exhaustively the literature on alternative therapies, I can say that other than the dietary therapies, modified Atkins and ketogenic, there is extremely little scientific evidence. Neurofeedback is a fascinating one because Barry Sterman devised that back 30, 40 years ago, published a paper in Science, which is the nation's leading scientific journal, and that was done on cats. And he actually could suppress seizures in cats using neuroEEG feedback. The challenge is the way it's being done now, sadly, in my view, is, and I hate to say this, is largely a for-profit venture. There's no science that it works. There's no science that it does reduce seizures. And so people get nice color printouts and fancy charts and can point, there's too much theta here and too little delta there. And I've probably seen 200 people who have gone for neuroEEG feedback with, I think, good people. from Dr. Sturman in California, he's at UCLA or was there, to people in the New York City area and elsewhere. I can't say I've seen anyone I felt has truly benefited. So, I think we need more research on all of these things because some of them may well work, but we just don't have any evidence that they do. And the last thing I'll say is keep in mind the law of unintended consequences. So when we don't have data, yes, there's absolutely a chance, and everyone's intuition is right. There's a chance that something could work, some herb from China, and it may. I'd have no data that it does or doesn't. But what I will say is there's been times where there's good scientific evidence. For example, I think it was the Women's Health Initiative where they looked at 50,000 women, and from that they said hormone replacement therapy is a great idea for postmenopausal women, and also vitamin E would be very helpful for heart disease and reducing colon cancer. It turned out not only was it not helpful, it was harmful. Hormone replacement therapy had increased rates of thrombotic heart disease problems and cancer, and actually vitamin E either had no effect or made heart disease worse and colon cancer worse if it had any effect. So again, things that seem natural and good when used as drugs or an unnatural way can be harmful. So again, I'm agnostic. We need more data.
We're still getting a lot of questions. I think we're going to go over just a little bit, but that's okay because your talk got started a little late if you have a few more minutes.
Okay, I'm here.
Great. So I'm just going to summarize what I'm seeing a couple of questions all asking about. Basically, they're seeing patterns in the type of nocturnal seizures their child is having and wondering if they should try to alter sleep schedules based on that, if that would have any help, like, maybe not letting them fall as deeply asleep at first, gently waking them up a bit, letting them go back to sleep, or getting them up early, that kind of thing. Do you think that would have a benefit?
I think it might. I think, again, it's not been well studied. And I think for parents, it's worthwhile to do simple things. I would do it gradually. I wouldn't radically shift a child's sleep cycle, but maybe move it progressively 15 minutes every 3-4 days or something would be one way to do it. Or I know some parents want to get meds into them so the levels are good. And I do have parents who, put their children to bed at 9 o'clock, but wake them up at midnight to give them a short-acting dose. I do think the most important thing probably with sleep-related seizures, if they're mainly in sleep especially, is you have the luxury of trying to concentrate the doses of medication for that child or young adult more around sleep. So let's say a child only has seizures at 5 to 7 a.m. when they're coming out of sleep, which would not be a rare pattern in Dravet. Then I would push to give a child like that a higher dose of an immediate release or shorter acting half-life medication at bedtime. So the levels peaking when they're about to wake up or waking up. And then during the day, the level of medication can be lower because if that's not the time that child has seizures, they don't need to be covered quite as heavily during the daytime, which is good. You minimize daytime side effects and maximize sleep control. So I do think all those things are doable, and you just have to be systematic and keep in mind, as any parent with Dravet knows, things happen for reasons you can't predict. So often there's no change in meds, no travel, no change in time zones, no change in sleep, and a child has a cluster, or a child goes 2 weeks or 6 months, God willing, without a seizure. So sometimes you may have given them peanut butter and jelly and convinced, they're 6 months seizure free because I got Skippy instead of, obviously that I'm being facetious here, but humans find patterns. We're incredibly good at finding patterns. And all I can say is most of the time we find patterns, doctors and scientists included, we're wrong.
Great, thank you for that. Let me see. I have a couple questions just asking about other associations between different medications and cognition. Do you have any other comments on that?
Yeah, I think there are some medications that are known to have potential cognitive side effects. I think all medications that work to control epilepsy or even behavior psychiatrically have to get into the brain to work, and they have to modulate either chemical or electrical activity or both ultimately. And so they all have the potential to, unfortunately, have negative effects on cognition. Fortunately, most drugs don't at the standard doses. Drugs that have been most notoriously associated are probably phenobarbital as well as topiramate. although it varies tremendously. The challenge for me with drugs like topiramate is that if I give it to a healthy 30-year-old woman who has migraine, she'll tell me if she has word trouble finding, and she'll tell me if her short-term memory is impaired. But when you give it to a 3-year-old child who has a limited vocabulary and cognitive functions as any 3-year-old, assuming they're fully normal, it's hard to really assess a difference. And especially if they get put on the med and it slowly increases, it's hard to know who's your child on meds versus no meds. So I do think it is something to be aware of, and it can be hard for a parent or the neurologist caring for the child to determine it, because you get used to what you get used to. And if the child does have cognitive delays and has been on drug X for a long time, but in general, the more medications, the higher the doses. And the other category just to be wary of, I think, are the benzodiazepines. The most frequently used, of course, in Dravet would be clobazam or Onfi, which can be a life-saving and incredibly valuable med. So I think, that's the yin and the yang. These drugs have incredibly beneficial and potentially harmful properties, and we just have to be careful observers and consider the effects.
I think we're going to do one more question. And then if anyone still has a question that didn't get answered, again, email it to me or email it to Mary Ann, and we can reach out to Dr. Davinsky and try to get your questions answered. So I think another question that I saw a couple times in here is asking your advice, if you have recommendations on what the best nocturnal seizure detection devices are for parents to consider.
Yeah, so I think it's a good question. I think there are more coming down the pike. There are 2 or 3 major ones that I think are used. Certainly a sound monitor is a good thing to do just because it's so cheap, and almost everyone who's a parent has a baby monitor from the early days. So that would be one thing as a backup. And then I think depending on the child and the weight, there are monitors like the MFIT that can go under a mattress and detect movement. Again, it requires that the seizures have a convulsive element to them. And the same is true for the 2 major wrist company, the Embrace by Empatica, and then also Apple smartwatches. And there are other ones that I think are available in Europe as well. And then there's the SAMI, which is a infrared motion detector camera that can be used as well, which some parents have found very helpful. Part of it is also all the kids are different and the seizures are different. And Doug Nordley wrote a paper a while ago on seizures and Dravet syndrome, and many seizures in kids with Dravet don't fit the classic boxes of what the epileptologists categorize seizures as. And so some of them may have convulsive movements, but they may be very fine movements, in which case none of these devices will work terribly well. So the bottom line is, one thing to consider is actually getting something that measures oxygen. There are oxygen monitors that can alarm, and you can essentially wait till your child's sleeping for 10 minutes and then just put something on their toe or their finger. Obviously it can come off and you just have to keep an eye on it. But for the real problem of SUDEP or status, the oxygen level is going to go down before something tragic happens. So that's yet another consideration. And for the younger kids, there's a device called Owlet, which will look at that. It's really for monitoring SIDS, and I think they're now making it for some older children as well. So I think there's no best one for everybody, because it depends on a specific child's seizures. And I do think, as the previous question said, this is an area we could do more research systematically in a disorder like Dravet and really study them. So I think when kids, for example, get a home EEG, that would be a good time to simultaneously assess different monitoring equipment. And that would be something I think would be ideal for a multi-institutional, multi-parent study where everyone just tracks it and we can see which type of seizures are recorded, which ones are missed, and we'll learn a lot and hopefully save lives down the road.
Great. Thank you so much for giving a talk for us today. Thank you so much for taking time and for staying over to answer all these questions. Feeling we might end up funneling a few more questions to you.
My pleasure. Happy to be here. And DSF and the Dravet population is very, very close to my heart. So
great. Thank you. I think the community appreciates it immensely.